This 31-year-old patient was referred to me for endodontic treatment of tooth number 12. According to the patient, 6 months ago, his dentist had tried to do the root canal, and after hours of working on the tooth, told him that he couldn't do it and he needed to go see a specialist. So it took the patient 6 months to come see us, but when he did, this was the condition of the tooth. As you can see, there's a temporary filling. I don't know what that is. I'm going to assume this is calcium hydroxide. But remember, calcium hydroxide doesn't work like this. You need to fill the entire length of the root canals with calcium hydroxide. Calcium hydroxide works on contact. It's not like you put a little bit of calcium hydroxide in the canal and then the bacteria will come to it and eat it and die. Bacteria are not mice or rats that you could, put out some poison for them and then they'll come to it and they eat it and they will die. Bacteria, they're throughout the entire length of the root canal system, and you literally need to obturate the canals with calcium hydroxide because calcium hydroxide works on contact. Remember that. So anyways, tooth was tender to percussion and palpation. Probings were 2 to 3 millimeters all around. And again, you can see based on the radiograph, I'm assuming this is calcium hydroxide. And you can see a large periapical relucency associated with the tooth. Do I need a CBCT? I do not. If you are more comfortable getting a CBCT, go ahead. I don't need to get a CBCT. Let's look at a different angulation PA, and immediately I can see that there are two canal systems. That's one right here, and that's another one right there. And this is another angulation. Anyways, if you want to get a CBCT, by all means, go for it, get a CBCT. I don't need it. I don't need to charge the patient extra money, and I don't need to expose the patient to unnecessary radiation. So we discuss options with the patient. As I said, this is a young guy, and he wanted to try to save the tooth, and that's what we did. So let's go ahead and switch to the point of view video, clinical video of how I was able to do this root canal so quickly when, according to the patient, his dentist couldn't do it after spending hours on this tooth. Local anesthetic goes in. I'm just fast forwarding this a little bit. Always give a palatal injection also. Always. And I warn the patient, it's going to be a little bit uncomfortable, but I always give it. Because when you don't give it is when you put the clamp on and patient says, it's pinching my gum. Or when you're into that palatal canal and patient starts to feel it and you wish that you had given a palatal injection. It's just an infiltration. All right. Rubber dam goes on. Rubber dam clamp. This is a premolar clamp. I usually put it on a posterior to the tooth that I want to work on. So I'm probably putting the rubber dam clamp on tooth number 13, the second premolar. And this patient salivated so much, we constantly had to suction for him. And that's fine. Just make sure your patients are comfortable. I'm just repositioning the rubber dam clamp. Constantly, he salivated so much. It's like he couldn't swallow his own saliva anymore. And that was the case even before I gave him the injections, So he's just like, he forgot how to salivate. And then he said he was feeling the clamp. See, I gave him 2 buccal infiltrations, and he said he was feeling it. So I didn't dismiss him. I didn't say, oh, how is that possible? I already gave you a bunch of injections, No, he wouldn't lie, So he said he was feeling it. So I'm giving him another injection. It's not a big deal. You guys make it so personal, like you take it so personally. Oh, I gave you already 2 injections. I gave you 2 injections on one side and another injection on the other side. There's no way that you could feel it. None of that stuff. I feel it. All right. I'm sorry. I'm going to give you another injection. All right. Here we go. So assuming that this was a retreatment, because I wasn't sure what this dentist had put in the canal or canals, I went ahead and I'm using the thick rubber dam, just in case if I need to use chloroform. This rubber dam is very resilient to the effect of chloroform. All right, frame goes on. Then the next thing my assistant will do is wipe everything down with 70% isopropyl alcohol. She's going to suction around the tooth and then wipe everything down with 70% isopropyl alcohol. Just disinfect the surgical field. So let's take a look and see what we got. All right, it looks like I put the clamp on the tooth itself, tooth number 12. All right, let's go ahead and get it going. Going through the temporary restoration that the dentist put in the tooth. One assistant on my left side is suctioning. The other assistant to my right side is blowing air on the tooth and the mirror, getting rid of the debris. 6-handed endodontics. It's fantastic. I'm just taking my time with the endo access. I don't want to perforate. I don't want to cause any issues unnecessarily, as you can see right there. Now I'm using my Endo Explorer and pulling out a cotton pellet. You can see my assistant is going to remove it. All right, so let's see what we got here. All right, so it is, as you can see, it's yellow. So that tells me that what we saw in the pre-op PA, the radio opacity in the coronal part, couple of millimeters of the canals, was calcium hydroxide with iodoform. As you can see, there's still some cotton pellet bits and pieces in there, fibers. All right, so I asked my assistant to give me my ultrasonic device, Ultramint Pro by 8 Teeth, and a little bit of 2% hypo. Let's ultrasonically activate, clean, and remove a little bit of the temporary filling material and all the cotton pellet fibers. All right, look how nice and clean now everything looks. And my assistant to the right is suctioning for the patient. All right. Take a look here. I can see 2 canals, buccal and palatal. I just want to see why this dentist worked on this tooth for hours, according to the patient. Couldn't do it. Anyways, 6% hypo. Let's go ahead and remove that little bit of calcium hydroxide that this dentist put in the canals, the coronal couple of millimeters of the canals. Pay attention to how I'm using the irrigation needle and hypo. Minimal pressure force on the plunger, and also I'm not allowing the irrigation needle to bind to canal walls. Up and down, moving it around, not allowing it to bind. Still cloudy. Calcium hydroxide is coming out. See, I haven't even done anything. I haven't even put any files or anything like that up the canals. Just trying to explore and figure out what this dentist has done for hours working on this tooth. Again, my assistant is suctioning for the patient. When you see the rubber dam move to one side, that means that my assistant is suctioning for the patient. Or sometimes I suction for the patient when my assistant is busy doing something to my right, getting me the next instrument or mixing sealer or what have you. It's teamwork. So I do it. All right. So I asked my assistant to give me a 10C file attached to my M4 reciprocating handpiece. And let's see how far up the canal we can go with just a simple number 10C file attached to my M4 reciprocating handpiece that I run at 1000 RPM with the torque off. So it seems like both canals are pretty open and patent. So I got a little catch there. See, there's a little catch there. And I think that's what this dentist encountered also. Encountered a little catch. But it's right there. It was in the palatal canal. And I believe there was a fin there. And the dentist's file would probably get stuck inside of that fin. And he just could not get it clean and open. And I admire this dentist, the fact that he just referred the case, didn't mess it up, or worse, perforate it or something like that, and then say to the patient, hey, just extract the tooth. So again, irrigation with 6% hypo. And again, pay attention to how I'm using that 6% hypo. All right, so let's go ahead and use the microsuction. See, I don't blow air in these premolars. I don't want to cause subcutaneous emphysema. So I just remove the hypo from the pulp chamber and part of the canals. Everything looks nice and clean. My assistant is suctioning for him. We sometimes leave the suction in the patient's mouth, but sometimes they don't like it, and this patient didn't like it. All right, so let's go ahead and see if we can get the working lengths. I'm using the fine pex apex locator by 8 teeth. And take a look. These working lengths are long. Look at that. This is a 31 millimeter file. All right, so that's one. Let's look at the palatal side. And again, it's very important for you to remember your reference point, because you don't want to forget your reference point and then wing it and then end up either instrumenting and obturating short or instrumenting and obturating long. All right, so we got the working lengths, and let's go ahead and use 6% hypo again. And let's go ahead and go to a number 15 C file. So the working lengths turn out to be 25 millimeters. As you can see, I'm using a 25 millimeter number 15 C file right now. That was the buccal canal, palatal canal. Again, this is an M4 reciprocating handpiece. And those are just regular, they're K files, but they're C files, which means that they're stiffer than regular K files. But the handle and everything is the same, as you can see. The plastic handle and the M4 reciprocating handpiece grabs the handle of a regular K file. In this case, a C file right now. Up and down, 1,000 RPM. I'm not only instrumenting and shaping the canals, I'm also sonically activating the hypo. After each instrument, copious irrigation with 6% hypo. You can see how much hypo I'm using. Need to get rid of the necrotic tissue and bacteria. Files that I'll be using to instrument and shape the canals further are these files, Easy Shaper files by Rogen, and Super Flexi Gold files by Rogen. And you can, if you live in the United States or Canada, you can purchase these from flexivodental.com. They're great files. I really like them. Okay. flexivodental.com. All right. Super Flexi Gold and Easy Shaper. All right, 25 millimeters going in. Just again, pay attention to how I'm using these files. I'm running them at 350 RPM. Recommended RPM is 300 to 400. I'm running them at 350 right in the middle. All right. Don't force the file. Make sure that you don't force it. If he doesn't want to go, he doesn't want to go. I'm in the palatal canal right now. My reference point, the buccal cusp, 25 millimeters. And look how much dentin it removed. These are really nice, sharp files. 6% hypo goes in. And look how deep I push the irrigation needle. Irrigation needle to the hub is 23 millimeters long. So I'm going to 23 millimeters. So I'm only 2 millimeters away from the working length, from the apical foramen. All right. Next file in this series of these files, again, 25 millimeters. I don't push it. I don't let it bind and just keep it running. When it's binding, that's when you break the file. I've already, look at all of that debris. Did you see all the debris? Had my assistant clean it, and then we're gonna go to the palatal. I don't let the file just run and sit. See what I mean? That's when you break a file. Up and down, don't let it bind, and don't force it. Very good. Look how much debris. So we're cutting good amount of dentin here to get rid of all the infected, contaminated dentin. And of course, removing all the necrotic pulp tissue as well. Again, back in with 6% hypo, and you can see how deep I'm going with my 6% with the irrigation needle. Maybe a mil or two away from the apical foramen. All right, suctioning for the patient. All right, that's it. I'm done. I am done. Let's cone fit. 25. Up and down, up and down. That's another way of activating. Poor man's version, as they say. All right, let's see if we got 25. Palatal. Measure to working length, up and down, activate the hypo. Measure to working length from the reference point. If it's long, then I cut whatever amount that is long. And that's how I make my own custom made master gutta percha cones. Isopropyl alcohol, 70% final rinse. Helps with the drying of the canals, the 70% isopropyl alcohol. Microsuction to remove most of the liquid, 70% isopropyl alcohol. Very nice. I'm just inspecting just to make sure I haven't missed anything. Everything is good. Everything is clean. All right. sterile paper points to further dry the canals. That's one way of seeing if they join at any point. I know they don't, but I just always double check. They didn't. Again, my assistant is suctioning for the patient. Very nice and clean. All right. Gutta percha dipped, master gutta percha cone dipped in AH plus sealer. I sometimes use my sterile paper point. In this case, I didn't. Just to show you that you don't have to use your paper point to coat the canal walls with your sealer. You can also use your master gutta percha cone. All right. So palatal now, master gutta percha cone dipped in AH plus sealer goes into the palatal canal. All right, very nice. I got a nice tug back, always ensure. System B, let's cut the gutta percha and thermoplasticize the apical portion. My assistant is suctioning the smoke. Buchanan number 2, plugger to condense the gutta percha. Keep a little bit of apical pressure for a few seconds. And Obturation 3 max to further obturate the coronal portion of the canals. And that's pretty much it. We're done. Buchanan plugger number 2. And we're going to clean the pulp chamber walls with 70% isopropyl alcohol and put our temporary filling in there, sponge, sterile sponge, temporary filling, and this patient is done. All right. Isopropyl alcohol used to clean the pulp chamber and air. Very nice. As I said, next is sterile sponge. There was one area that was bothering the heck out of me, and there was a little bit of cotton pellet fiber that I could see under the microscope, and I didn't like that. So as you can see, we're very OCD. So I asked my assistant to give me the ultrasonic unit, Ultramin Pro by 8 teeth, and I'm just gonna clean that part with 2% hypo and ultrasonics and removed that piece of cotton pellet that was bothering the heck out of me. Anyways, wouldn't have mattered really, but I'm just so OCD. If that cotton pellet, that little bit of fiber, is communicating with the patient's oral cavity, it would wick saliva and bacteria from the mouth to the inside of the tooth and contaminating my beautiful root canal. So as you can see, I cleaned it all up. All right, now I'm happy. Okay, I think I'm happy. All right, yes I am, because if I wasn't happy, I wouldn't have let it go. I would have done something to make sure that everything was good. I treat everyone as though they're my family members. I'm super OCD. All right. Cavit goes in. And you already know the rest. All right, let's go look at the post-operative graphs. Okay, so this is just cavit. I'm just putting cavit in, and then the rubber dam is off. The rubber dam comes off. And my assistants will be cleaning the patient and taking a couple of multiple angulation PAs. This is what we started with. And again, according to the patient, the dentist worked on this tooth for hours and told him that he couldn't do it. He couldn't complete the root canal, do the root canal, and he needed to go see an endodontist. And we were able to do this root canal for this patient in, I believe, 35 minutes. All right, so let's look at the post-op. But this is what we started with. And here is the post-op. So as you can see, everything went beautifully. And we were able to take care of this patient and get him out of here quickly. No pain, no issues, no problems. We made sure he was comfortable. Working lengths were 25 millimeters long. And again, I used these files, the Super Flexi Gold and Easy Shaper files. You can purchase them if you live in the United States or Canada. You can purchase them from flexivodental.com. I put the link under the post, but perfect. And we referred the patient back to his dentist for the permanent restoration. Just another angulation. Another angulation. And another angulation. All right. Very good. I hope that you like these videos. If you do, please make sure that you subscribe. You push that like button, press that like button. Comment and share. Tell your friends about our YouTube channel. You can also follow me on Instagram and TikTok at Advanced Microendo. And hopefully you enjoyed these point of view clinical videos. I have many more that I can make. They take a lot of my time. I've been here since 5 a.m. It is 6:43 now. So I spend a lot of time on these videos and making them and editing them and all that stuff, making them ready for YouTube. Hope, again, you like these videos. Make sure you subscribe, you like, you comment, you share, and see you guys in the next video. Bye-bye.